Hello and welcome to the Healthcare Today podcast. Our guest today is Fiona Hazell, the Chief Executive of Leukaemia UK. Responsible for leading the charity's strategic goals and driving progress for people affected by leukemia, Fiona is charged with raising awareness of the devastation caused by blood cancers. The fifth most common cancer type in the UK and the third biggest cause of cancer deaths, leukemia is nevertheless consistently overlooked in a system designed around stageable solid tumours. Today we're talking about the government's new National Cancer Plan, the vital importance of early diagnosis, and a hope for real change. Why is the new National Cancer Plan so critical for leukemia patients compared to previous strategies?
Yeah, first of all, I think we need to understand that blood cancers really are the fifth most common cancer type in the UK. So that's impacting hundreds of thousands of people, and they're also the third biggest cause of cancer deaths in the UK. And then for leukemia, you've got around 60,000 people in the UK who are living with a leukemia diagnosis. So you've got a significant population that until now, cancer sort of strategy and policy hasn't really addressed. In fact, certainly for people affected by leukemia, they've been consistently overlooked in the system because policy has naturally focused on sort of stageable solid tumours, which obviously make up a lot of cancers. So in this National Cancer Plan, for the first time, leukemia and rare and less common cancers more generally really have been meaningfully embedded throughout that national cancer strategy. And so those new commitments that you see in the cancer strategy really could be transformative, both for the diagnosis, treatment and care of people affected by leukemia. So I think, we sort of feel at Leukaemia UK that it really it sort of marks a really significant step change in sort of policy recognition and progress for people affected by leukemia. In probably the last decade, I think there's been about sort of, three cancer strategies over the last sort of 30, 40 years. So to finally have that recognition for people affected by leukemia and rare and less common cancers is really a milestone. So it's really great to see.
The National Cancer Plan has made certain commitments, including a target for 3 in 4 people with cancer to be living cancer-free and well beyond 5 years from their diagnosis by 2035. An alternative metric for leukemia and blood cancers to be introduced, and a new campaign to offer a personalised needs assessment to everyone with cancer at the point of diagnosis. Big question, is that enough?
Is it ever enough? Well, I think we have to be really fair to the National Cancer Plan, actually, and the people that have worked on it. There's a huge amount of commitments and thought in there around people affected by blood cancers and leukemia. Of course, it doesn't cover everything, and there's probably some other things that we'd like to see, but I think it is a really major step forward for people affected by leukemia, not least because I think the commitment around the new metric to reducing the number of cancers diagnosed in an emergency setting, which we might come on and talk about in a bit, something that we've really campaigned relentlessly for with our supporters and patients. That really is a major step towards improving early diagnosis for leukemia. So that's got to be welcomed. Leukemia, as you will know, is a really complex cancer. So the treatment for leukemia is really complex also. Patients experience, in some cases, very long treatment sort of journeys and care journeys. Diagnosis is difficult. And actually the treatments are often still very harsh and toxic. So they really need really strong support in and around them, particularly if we want them to contribute effectively to society and we want them to live well. And so I guess one of the other key commitments in the National Cancer Plan is around sort of personalised needs assessments and patients getting plans that support their physical, mental and social needs. There have been previous commitments around that, so it's going to be a challenge to deliver, but I think we were delighted to see that recognition around that. Also, you've talked about the real ambition around improving survival in rare and less common cancers, including leukemia. And I think this is a really fundamental commitment and really, really important because the National Cancer Plan will not be able to deliver on its broader goals of improving survival overall and quality of life overall if it doesn't really tackle the issues in rare and less common cancers like leukemia. And so commitments like having sort of leads at sort of NIHR and sort of national clinical lead, they're really, really important commitments to help drive forward some of the progress that's needed there. And as a medical research charity, Leukaemia UK is really delighted to see that. Other commitments like the recommitment to the sort of 28 days diagnosis waiting time standard, Obviously, that's been around a while. It's not been met consistently for leukemia for some time, but it remains really critical. It remains a challenge to deliver, but we're glad to see it in there. And then I think that investment, that commitment to investment in research in rare and less common cancers, and also increased participation in clinical trials, which has all been sort of come about through the Rarer Cancers Bill that we've supported. That's really great to see. Leukemia and leukemia patients really rely on treatments. Surgery, radiotherapy is not something that's used in most treatment of leukemia. So getting access to life-saving treatments and treatments that can improve quality of life and making sure that the research and the investment in research is there to drive those future innovations are really critical for cancer patients in years to come. So again, another great thing to see. So I think when you take all of those things together, is it enough? There's a lot to get started on, and we're really keen to get going.
You mentioned about A&E diagnosis. Now, the statistic that 37% of leukemia cases are diagnosed in A&E seems to be rather staggering. What does that moment of emergency diagnosis mean for a patient's treatment options?
Yeah, isn't it a staggering statistic? I think just in terms of sort of, I guess, the context behind it, it definitely tells a story. There's a lot going on behind it. And obviously, we're always really keen to understand what is going on behind it, both in terms of patient experience, in terms of the evidence, and then the sort of possible solutions. In terms of what it means, I mean, I was reflecting on this earlier today because I think there's the what does it mean in terms of outcomes, but what does it mean for patients in terms of their experience? Being diagnosed in an emergency setting is scary, and it often comes quite suddenly, and that's not the best way to be diagnosing patients. And often, sort of, you have to wait to get then the right sort of advice, the right diagnosis, the right expertise. So I think we need to remember that literally from a patient perspective, diagnosis in emergency settings is not ideal. Sometimes it's really important and it's a very effective way of diagnosing cancers, but obviously it doesn't, it's not necessarily the greatest experience. But on top of that, we know there's a lot of evidence to show that emergency diagnosis of cancer and emergency presentation generally leads to poorer outcomes. And that's, that's largely because the diagnosis is coming too late. So there have been symptoms that have either gone unreported or undiagnosed for some time. And so particularly when it comes to leukemia, and particularly acute leukemias, that diagnosis or that disease onset is very rapid. And so early treatment is really, really critical. If you think about sort of treatment of blood cancers at the moment, it's really, and cancers more generally, and in fact other diseases, it's really starting to benefit from some very innovative treatments in terms of immunotherapy and CAR T therapies. But patients have to be well to receive those therapies. Those therapies are very tricky to deliver, and so the patient's got to be well enough to receive them. So late diagnosis and an emergency presentation does not sort of set us up for that kind of really innovative sort of leukemia treatment and care. So we've got to understand it and we've got to address it. So the metric around improving and reducing diagnosis of leukemia and other rare and less common cancers in an emergency presentation is really significant. And I think it's a real recognition of the issue. And I think that's important in and of itself, but also that there's a determination and ambition to try and change that.
If we were looking at acute myeloid leukemia, the difference in 1-year mortality between emergency and non-emergency diagnosis is stark. It's 67% versus 48%. Obviously, this isn't just a stat, this is about people. How can we communicate this urgency to policymakers who are balancing a huge amount of priorities at the moment?
Yeah, I mean, it's a really great question, and it's something we think about a lot because we are really acutely aware of the challenges that the NHS and policymakers are under. I think, I mean, it's, what, a nearly 20% difference. It is really significant. And for the sort of 3,000 people affected by acute myeloid leukemia, and it affects all age ranges, it makes a huge difference to outcome. And so we have to do something about it. I think to answer your question about how do you communicate that urgency and sort of balance that against sort of, the sort of appreciation that there are countless priorities, I think it's a combination of things, really. I think you have to start by enabling patient voice to be heard. And we feel that for a while, sort of the sort of voices of people affected by leukemia has been a bit lost in some sort of national cancer policy. And when you've got sort of survival of a cancer like acute myeloid leukemia, which stands at 22% over 5 years, you've got to I guess you've got to kind of bring their stories and their experiences to the fore and enable them to share those stories. I think the other thing you've got to do is you've got to look at the evidence at a system level. You've got to have the data, if you can, to support and I guess sort of create the foundation for those stories to be really taken seriously and heard. And I think those two things together can help policymakers to understand the importance of recognizing the issue and then addressing it and then thinking about what the solutions are. And I think that's the third bit is, you've got to come with some solutions, ideas that could really help deliver change in this area. In I guess in health policy and in cancer policy, there's so many things to think about. There's so many different types of cancer and there's so many different challenges. And there's a real range in terms of outcome, both in terms of cancers, in terms of geography, in terms of different backgrounds. And so it's really hard for policymakers to really understand it all or even see it all. So it is the job of charities like Leukaemia UK to work with our supporters and patients to really tell that story, to give them the evidence, but also to give them the personal testimony. And I think what's really interesting about this strategy is I think some of the people who have been driving it at the top have their own personal experience of rare and less common cancers. And I think that is really important, that shared experience and that real commitment to do better. We know that in acute myeloid leukemia, because it develops rapidly and it requires urgent treatment, that if we can improve the diagnosis of AML and get that right, then not only is it going to help meet the kind of survival and quality of life outcomes that this strategy is looking to achieve, but it's going to save the NHS money and time, and it's going to make the experience for patients that much better. So, I think trying to understand the issue, share the patient experience and story, and let patients tell that story in their words, and then evidence the benefit it can have for all is really critical.
Now, as the old adage goes, if you want to make God laugh, tell him your plans. Taking away targets, what are the most practical, fixable barriers to your mind in the diagnosis pathway right now? Is it clearer GP training, phlebotomy access, or I always trip over that one, or something else?
Yeah, I mean, I think one of the ironies I think in leukemia is that there is already actually a really simple, quick, low cost test to rule out leukemia. It's a full blood count. It's probably, I would imagine, one of the cheapest sort of cancer tests, diagnostic tests that you can get. So I think when it comes to thinking about sort of practical barriers beyond the targets that will really make the difference, there's probably sort of three areas I think we would look to focus on. And the first one is God loves a plan, as you say, I think, but actually more than a plan, it's about really clear pathways and really clear guidance for healthcare professionals, for the community that can deliver consistent diagnosis. And so that everybody knows what good looks like and can work to that. And actually, there isn't, a clear pathway for the diagnosis of leukemia and other blood cancers. And we've been working with charity colleagues at Myeloma UK and Lymphoma Action on the best practice time pathway to help with that. But I think the other things that we think could really help, looking at different sort of ways that full blood counts could be accessed. There is definitely a real challenge in getting access to full blood counts in the way that you currently get referred by the GP and then, sort of you have to go sort of through phlebotomy. I think the question is, can that look different? What can it look like? How can we improve that? Capacity is clearly an issue, but it's not the only issue. And then I think, good old point about technology. I think technology can really help us look at how we spot patterns in the reporting and diagnosing of leukemia. Leukemia symptoms are often non-specific as they're known, and they can be reflective of many other diseases. So they can be hard to spot, particularly when they're reported in isolation. But actually what we do know is that a lot of leukemia patients will go to their GP 4 or 5 times before they are diagnosed, and then often they are diagnosed in A&E because it becomes an emergency. And so if we can have some sort of technology, automated clinical prompts that would really help spot some of that, then I think that could really help. And we know that that is possible in other diseases and other cancers. So I think it's something we should definitely look at.
You talked about a best practice timed pathway with a 1-week specialist referral after an abnormal blood count. To your mind, is the NHS currently equipped to deliver on this proposal?
I think it is actually. And I think we know that in other cancers, it has really helped. I don't think it's a panacea, and I don't think it's the only thing that will help. But I think, as I was saying earlier, and as we've talked about earlier, having a plan and having some clear guidance, definitely is a good start. I think there's no nationally agreed pathway for guiding how leukemia patients should be diagnosed and treated within specific timeframes, which I think is quite incredible when you think about it, particularly when it's a complex disease and you've got a real range of sort of more chronic leukemias and acute leukemias where time really is of the essence. And then we know that we've got variation across the country in terms of ability to deliver, in terms of inequalities, and in terms of, sort of specialist centres. So I think having guidance which tries to sort of draw that together can only be a really good thing. And I think that we think that it could really help with sort of faster transfer between clinical teams, referral to sort of specialist in an appropriate timeframe, and also sort of streamlining of the diagnostic process. I think we can all see that there are opportunities to improve efficiency. I talked about patients going 4 or 5 times to a GP, and that just does not feel like a particularly productive way to diagnose, a deadly cancer. So we think it will really help. We are really proud to be leading on the development of that alongside Lymphoma Action and Myeloma UK, and of course NHS England Cancer Programme. And I think that, we're really hopeful that that can really help lay some of the foundations around diagnosis going forward.
Given that UK survival rates for leukemia lag behind other cancers and behind Europe as a whole, how do you manage the balancing of the messaging of an urgent crisis with one of a solvable hope?
Again, a really good question. I mean, I think it's going back to some of the principles I talked about earlier. It's about evidence, but it's about sort of patient experience and voice. But I think it's also about trying to, balance the short with the longer term. We know as a medical research charity, we're very committed to funding really innovative research which can really help patients in leukemia, both in terms of improving survival and quality of life and understanding the disease more broadly. And so I think you've got to be able to provide hope through that. And we know that research is driving innovations in cancer, and that there's a strong track record in the UK of doing that. So I think you can talk to that. And we know there's a huge talented pool of researchers, blood cancer researchers and hematology experts who are really driving transformation in leukemia treatment and care. So I think you've kind of got that longer term, more hopeful piece. And then I think it's about accepting, as we've talked about, that, having a plan and having guidance is really important. We know that having a clear cancer strategy internationally, there is evidence to show that having really clear cancer policy articulated through a cancer plan or strategy correlates with improvements in outcomes, including survival. And so sort of really supporting those that are able to deliver that, to create it, is really important. And then I think it's about trying to be specific and be really clear where you've got evidence, whether that's patient voice or sort of statistical evidence to show where there are issues, and then bringing those together into sort of actionable solutions. I think that what's really interesting about this strategy is the recognition, I think, for rare and less common cancers. And, I think a big shout out to sort of our colleagues at Cancer 52 and other charities that represent rare and less common cancers, that there is a dedicated chapter to that. I think that shows real recognition about the importance of less common cancers going forward, but also a dedicated chapter to children, teenage and young adult cancer. Leukemia is the most common childhood cancer. So again, we really welcome that. I think it's really about breaking it down into sort of manageable chunks and then trying to provide the evidence and provide solutions to sort of get that balance of messaging right between the urgent and the need, and the hope and the ability to solve. And I think, a lot of this is about working in partnership that, if there were quick fixes for many of these things, we'd be doing them already. So a lot of it's about working in partnership to come up with solutions together.
What, to your mind, can healthcare professionals and, by extension, the general public do to support this call for change?
I think the first thing to say is, I am struck daily by the haematological workforce and the great job they do, and sort of the people that I meet who are so committed to patients and improving their experience and their outcomes. Many of them are delivering, well, they are delivering a huge amount already, but many of them are delivering like really complex treatments and care brilliantly, whilst also leading the way in finding new ways to deliver sort of cutting edge treatments and care, such as CAR T, and actually even training other disease areas and healthcare professionals to deliver that CAR T. So, like in autoimmune diseases, for example. Firstly, I think at Leukaemia UK, we would say that there's real recognition needed for healthcare professionals in the community who are already doing a brilliant job in challenging circumstances. I think at Leukaemia UK, we're really interested to work with the healthcare professional community and patients, obviously, to understand the evidence and issues and to work with healthcare professionals to generate the evidence, because actually sort of data in leukemia is not great and we definitely need more of it. So we're really interested to hear from healthcare professionals about data that they've got or sort of data that might be needed. And we're also really keen to hear from them about ideas and solutions they've got to tackle some of the challenges and meet some of the commitments in this new cancer plan. I think having some of those commitments allows us all to sort of focus around how we might deliver solutions around them. So we're really keen to work with the haematology community and the healthcare professional community and cancer community more generally to really deliver on those commitments. And I think from a public perspective, there's so much the public can do. For example, understanding signs and symptoms of leukemia and not being scared to go to your GP if you are in any way worried about them, and asking for a full blood count if you are worried. So, equip yourself about what the signs and symptoms are and go to your GP if you're worried. And if you have family and friends where you think that might be the case, to encourage them to do the same, because early diagnosis saves lives and it's better to go and get it checked out than to sort of wait and then deal with a much more urgent or emergency situation. I think the other thing is, we're a medical research charity, and, we raise money to fund that medical research, and that is having impact on treatment and care today and in the future. So people can always come and support us. We'd love to hear from them. So there's plenty that public and healthcare professionals can do. And I think, like many cancer charities, we stand ready to work with healthcare professionals, policymakers, government, patients and the public to try and seize the opportunity that this cancer plan has created. It's just a start. Policy alone is not going to deliver it, but having the recognition and ambition there for leukemia and blood cancer is a great start. I'm really, really looking forward to getting stuck into it.
Fiona Hazell, thank you so much for your time. All the best for what's going to be an interesting couple of years.
Thanks so much, Glenn. It's great to talk to you.